Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with Genesis Care in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
Our next patient is a 31-year-old with a history of ER positive with a 20% positive, PR negative, HER2 negative, right invasive ductal carcinoma, treated with neoadjuvant doxorubicin, cyclophosphamide, and paclitaxel, followed by a modified radical mastectomy and post-mastectomy radiation that unfortunately now has developed a brain and leptomeningeal metastases. And so the question being raised is, what is the recommendation for sort of the next treatment? This patient presented with a 7-month history of a right palpable breast lump and associated pain. She had an excellent performance status, no significant medical history. She was G3, P3, no oral contraceptive or hormone replacement use, no significant alcohol or drug use, and no significant family history. She had bilateral mammogram and ultrasound, which demonstrated a 5 by 2.8 centimeter mass between 9 and 11 o'clock and a 1.2 centimeter mass at 9 o'clock with multiple nodular masses in the axilla and axillary tail of the right breast. In March of 2020, she had right breast and axillary biopsies. Both the mass and the periareolar masses demonstrated grade 3 invasive ductal carcinoma, which had an ER 20% positivity, PR negative, and HER2 negative. The lymph node was positive as well. She had CT, chest, abdomen, pelvis, and a bone scan, which was negative for metastatic disease at that time. She began neoadjuvant therapy with doxorubicin, cyclophosphamide, and paclitaxel. She underwent a right modified radical mastectomy with a residual 2.2 centimeter grade 2 invasive ductal carcinoma with negative margins and metastatic carcinoma identified in 2 of 14 axillary lymph nodes. In October of 2020, she began adjuvant radiation therapy to the right chest wall and supraclavicular area. She began tamoxifen therapy. In November, between November and December, she developed a new onset headache with associated recurrent vomiting. CT scan of the chest, abdomen, and pelvis demonstrated an increase in retropectoral lymphadenopathy, and imaging of the brain demonstrated a hyperdense lesion in the right temporal lobe, left occipital lobe with extensive vasogenic edema, and she had an MRI of the brain that showed a supratentorial dural enhancing space occupying lesion with abnormal meningeal enhancement. MRI of the cervical spine showed extensive nodular meningeal enhancement along the whole spinal cord concerning for leptomeningeal disease, and she had a lumbar puncture showing cerebrospinal fluid that was positive for metastatic disease. And Dr. Jockelson, if you might point out some of the findings here for us.
Certainly. So we have 2 views of her brain with different sequences, but this is such a terrible case for this poor young woman. So you can see on the images on the left in the posterior part of the brain, you can see that extradural, that tenting the bright lesion posteriorly, and then there is a second lesion more anteriorly behind the ventricles. And then on the second image, you can see a much larger lesion posterior to the left ventricle. And it's hard to say, you get the feeling that she had increased pressure, but it's hard to tell on these images. The one thing that I don't have, and I think would be good to know going forward after trying to figure out what to do after this treatment, the comment about the increasing retrocrural nodes. the initial CT was apparently negative. Now they're talking about the increasing nodes. And what I'm not sure is whether or not she had another, and whether we would have or not, but another CT chest, abdomen, and pelvis to see what was happening systemically to determine whether, she responded primarily to radiation and the intrathecal, but systemically what's happening. And I think that would be important information to have.
Thank you so much for that. We appreciate that. So she underwent whole brain radiation. She had intrathecal methotrexate, cytarabine, and hydrocortisone 6 weekly sessions. She subsequently had spinal taps, which demonstrated no malignant cells in the cerebrospinal fluid. And in April of 2021, she had an MRI of the brain that showed a treatment response, the largest left occipital lesion measuring 11 by 10 millimeters, which was decreased from 28 by 26 millimeters. And at this point, she has been placed on capecitabine. And so the question is the recommendation for next treatment options. So Dr. O'Shaughnessy, do you want to walk us through how you would approach this patient with this sort of low ER expression, PR negative, HER2 negative metastatic disease?
Sure. When you see a very young woman like this with this aggressive biology, grade 3, PR negative, HER2 negative, and the ER is real low, and particularly if the Ki-67 is quite high, it suggests that it may be more of a basal-like biology. So I always, I like to send these cases to Mayo Clinic. I find that they give a very good second opinion on ER, and I'd say about 2/3 of the time they come back ER negative. And then that's helpful because it can change your therapeutic strategy, whether it would make a difference in this woman's development of brain metastasis. But triple negative breast cancer, the treatment is very much an evolution with sometimes introducing platinum, carboplatin in addition to an ACT preoperatively, potentially the use of a pembrolizumab preoperatively in a node positive high risk situation, for example. But there are ER positive breast cancers that are basal-like. In the I-SPY 2 group, you have to have mammaprint high to get on if you're ER positive, and about 30%, about 20% of those or so are basal-like. If you take all ER positive, HER2 negative breast cancer that's going to get preoperative chemotherapy, it's 13% are basal-like, even though they're ER positive, and it can be weakly ER positive, it can be highly ER positive, because you have to look at PR, you got to look at Ki-67. So I would have repeated the ER on her. That's just me. Then when she had the residual disease, because I had a question mark about the ER, I would repeat the markers on her residual disease, and might even consider doing it on the initial cytology that was positive as well in her CNS, because if she's got real ER positivity, then I'd also be looking to come at, after the estrogen receptor as well with an LHRH agonist and an aromatase inhibitor. She's very young, so she probably didn't have full ovarian suppression with her chemotherapy. So I'd be looking at an LHRH agonist plus an aromatase inhibitor. But right now she's doing well with her CSF cytology clear and improvement in the brain after whole brain radiation. I think it's very reasonable to keep her on capecitabine, but I would probably consider even getting NGS on her breast cancer, even looking for, like, for example, a HER2 mutation, because we have therapeutic strategies that might even cross the CNS for that. But there are a variety of options. If she progresses again, she will likely need surveillance evaluation of her CSF cytology, and we have. It's nice if the patient has access to a neuro-oncologist. They do that very readily in their clinic and really are really excellent with the IT therapy. But she'll need surveillance, and she may need more intrathecal therapy. She's done well with those agents, and so repeating them, or even a topoisomerase inhibitor, topotecan, can be very helpful, or thiotepa. These are DNA damaging agents in the context of, no doubt, what's a high risk homologous recombination deficient cancer. There are a number of other strategies. Nancy Lin published a paper for brain mets now with carboplatin and bevacizumab. And these patients, there was a 63% response rate. Those who were HER2 positive got trastuzumab added, but there was the cohort that was triple negative also had a high degree of response with that combination. It's not on NCCN guidelines, but there's etoposide cisplatin. There is several phase 2 studies of etoposide cisplatin as another option that can help treat brain metastases. We're more limited on leptomeningeal, disease per se, but it's a close collaboration with the neuro-oncologist because this intrathecal therapy, I think, will need to be an ongoing option for her. I don't know whether she got cervical spine radiation too. She got whole brain radiation. I know.
I didn't see that. Yeah.
Right.
She got cervical spine too.
No, I said it probably would have been unlikely that she would have gotten it. It's pretty toxic together. Yeah. So you would just kind of monitor her for symptoms, I guess, and for just on imaging to see whether it just simply got better with maybe some intrathecal therapy. But I guess it could be monitored because she'll need maybe additional radiation therapy as well, particularly if things change before she gets symptomatic. Unfortunately, by the time patients get symptomatic, it's unlikely that they'll come back in terms of their neurologic function. So getting it, before they get symptomatic is very, very important from a radiation standpoint.
At what point, or do you ever consider looking for androgen receptors in a patient there's almost triple negative and also ER? At one point in a person like this who is kind of very difficult to figure out, would that be a consideration?
So the androgen receptors really are useful in a really luminal type breast cancer, whether it's a luminal ER positive or whether it's a luminal triple negative. And with this, I would bet I think we were told she's grade 3. I'll bet her Ki-67's high. And with that just whiff of ER positivity, it's very likely she's basal-like. And so the AR wouldn't be useful in that context. Also in this age group, it'd be very unlikely, because I think her biology is really triple negative. It's basal-like. Be very unlikely that AR would be playing a role in her disease. But I think it's really important to know whether ER is there to any appreciable extent, in which case going after that estrogen receptor, with an LHRH agonist and AI, I think would be something I would definitely do.
Perfect. Okay, so in summary, we would recommend confirmation of the ER status, possibly sending the pathology to Mayo Clinic for a second opinion on whether the ER expression is really truly there or not. If there is ER expression, consider an LHRH agonist and an aromatase inhibitor. Consider sending next generation sequencing to look for other therapeutic targets, careful consultation with neuro-oncologist, consideration of other therapeutic strategies like carboplatin and bevacizumab, or etoposide and cisplatin or thiotepa, but very careful surveillance and working with the neuro-oncologist.
I think the next gen sequencing is something that I would be enthusiastic about. Maybe she has a PIK3 mutation. Maybe she has a fusion gene. Maybe she has a somatic BRCA. I mean, these open up new options. And your point to solidify the ER status. I mean, all the data coming out suggesting that CDK4/6 inhibitors cross the blood-brain barrier. That would be an option that would give us additional latitudes. So I completely agree with the suggestion that we ought not be complacent here, even though she had a great response from the liposomal cytosine arabinoside. I mean, I think that's great, but I think it's important that we don't negate other options here. And the question for Frank, is there a role for stereo radiotherapy?
You're stealing my thunder now. You're exactly
I'm asking the question, not giving you an answer.
Well, that's what I thought we'd be asking whether or not to boost that area, but it's a couple of points. It's much too soon after the whole brain irradiation to assess how well that's responded there. I imagine the whole brain finished maybe a month or two beforehand, so the MRI is pretty recent. And also the whole brain radiation fractionation was pretty aggressive. So I think we're going to need a little bit more time before we would consider doing a stereotactic boost, but that's always there down the road, meaning in the next few months, should her other disease remain stable, one could consider giving a stereotactic boost, whether through gamma knife or LINAC-based radiosurgery. And then the other question, which was brought up, sorry for interrupting you, Joyce, was, whether or not someone would radiate the spinal area. The only time we would do that is if there was gross disease that did not respond and she became symptomatic from it. I think that'd be the only scenario where I would push that issue.
And just to bring up the germline BRCA too, because that would also, and germline BRCA and germline PALB too, because that would give her option of PARP inhibitor, and talazoparib and olaparib both have data of CNS penetration.
Perfect. Thank you, everyone, for that. That was great.